Baik Bapak Ibu, kita langsung menuju ke Singapura. Ini kan tadi pembukaan lagu Indonesia Raya dan Mars Pari. Dan kita coba kontak dengan Ketua Panitia yaitu Pak Gatot. Oh, belum ada Pak Gatot. Bapak Ketum juga tidak ada. Bapak Sekum juga tidak ada. Kita akan langsung menuju ke ke Singapura. Ya, seperti yang dilihat di layar, inilah ini kondisi di Zoom Singapura saat ini. Semoga bisa dilihat. Kemudian saya coba untuk connect audionya. Video settingsnya, ya, oke, biar lebih jelas. Kemudian saya akan coba kontak audionya. Oke. Dan
Sorry, Bichilura.
ya, semoga
Yes, sir.
bisa didengarkan.
How about Safari tell
Baiklah,
you
Bapak Ibu rekan-rekan, silakan
in November?
melihat
She said that they won't be
CPD
able
ASIA
to hold
ke-20
it.
langsung dari Singapura yang di-host oleh SSR, Singaporean Society of Radiographer. Dan Bapak Ibu silakan mengisi form attendance, form kehadiran yang ada di kolom chat.
Sorry, you hear me?
Kemudian nanti
You hear me?
form tersebut ada
she
form
tell in today,
untuk
she tell everybody
sertifikat.
in our
Silakan.
November in Cambodia can host in November.
Oh, so I'm gonna call her Madam Sophie Lee, President Sophie Lee.
Yeah, Sophie Lee.
Okay, all right.
Sorry, I will call him. I will call her now. Yeah.
How are you, Peachy?
Yes, hi Joyce, Mom Joyce.
Yeah,
We have a stormy weather. We have a storm. We have typhoon, strong one.
Still going on now?
Mm.
Okay, take care.
Thank you.
busy, Luna.
Yes.
Yeah. You hear me? Okay, you hear me? Okay. So will you tell me maybe in November, Cambodia cannot host SSPD. I think you can tell with everybody we can skip in November. Yes. And December we have a meeting in Thailand. Okay. Yeah.
Hi everyone, thanks for joining today. So I think Ms. Tan said that we'll open the Zoom at about 4:55 for everyone. And then we will start, PG will start at 5 p.m. sharp.
Hello, everyone.
Hi, President Fernando. Hi,
Hello.
President Yuan Tu.
President Fernando Kok, President.
Hello,
Next.
Luna. How are you?
Well, we have a typhoon here.
Yes, I saw the typhoon, but the typhoon
Yeah.
after the Philippines come to Macau
Oh,
2 days later, I think. Hello, Locke. Good evening.
Yeah, hello. Yeah. You hear me?
Yes,
Fernando?
sure.
yes.
Okay. Yeah.
Hello. For joining today.
Locke, how about the next month, the CPD about Cambodia? They will host or not?
I just correct Sophie President Sophie Lee, President in Cambodia. She just tell me cannot host in November. I think if she cannot, I think we skip the November. And December we have a meeting in Thailand.
Okay. But
Yeah.
any societies want to host on November to subsidize the Cambodia or not? Nobody want to host for the next month?
Oh, we're supposed to have India.
India, I don't know.
Supposed to have this month, right?
India, no, because India, Mr. Kumar told me they are very busy because they have many meeting on these 2 months. Because you know the India is a very big country and have a lot of members, so not easy to arrange a day. So he said on next year.
I think maybe if difficult, we just have to forget about November.
No, so no, the Taiwan, you want hold on next month to subsidize Cambodia or not?
No, because next week we will election our direct board.
Oh, right, yes.
Sorry.
Yeah.
After that, yes, the
Yeah.
Taiwan
Election
usually
again. Yeah.
November.
Election. November. Okay. If every cannot, we can skip in November and December. We have a meeting in 12 December. 12 December we have a meeting. After Pacific, the meeting Asia, we have a short meeting with Asia CPD.
Bangkok. CUO in Bangkok.
Yeah, CUO in Bangkok.
You, all of you, you're lucky. No need to guarantee when you're back to your country. So only
Yes.
Macau need still 7 days. I don't know. Trouble.
Yeah.
Yes, trouble.
Mm-hmm.
This government is trouble and trouble for Macau.
Mm-hmm.
There's still 7 days guarantee when I back to Macau need.
Oh,
But I hope
still 7 days.
7 days in hotel for guarantee.
Oh, yeah.
Trouble, yes.
Expensive.
Because they follow China.
Mm-hmm. Yes. In Hong Kong also.
Hong Kong no problem. Hong Kong Nelson there, right?
Yeah, Hong Kong no need. Just check in the airport and then can go home.
But still waiting. Any change out in December?
Mm-hmm. Oh, in Hong Kong, Nelson, in Hong Kong, you after go back in Hong Kong, you go home in 7 days at home?
No need. Yeah, they just check in the airport. No need to wait for the result, and then you can go home and can go to work.
Oh yeah, yeah.
Yes, but if you are positive, they will call you back.
Mm-hmm.
And then if you're positive, Nelson,
wow.
where you stay at home? It's positive in Hong Kong. What you need to do?
No, just stay at home and then report to the computer, to the government, and they will come to your home and give you the wristband to make sure you will not go out.
Oh, okay. So you need to stay at home.
Yes.
How many days?
7. If you have two vaccination or 3 vaccination, then 7 days is okay.
Okay.
Maybe only in Malaysia, in Vietnam, and Thailand. Maybe we forgot.
Singapore
in
also the first
COVID.
country, right?
Yeah, we forgot. We don't remember in COVID.
Welcome to Singapore.
Oh yes, hello Joyce.
Hello.
Yes. Yeah. Hello.
Hi everyone. Good to see everyone again.
More 2 minutes.
Hi everybody. Sorry I came in a little late.
Yeah, no.
Can you hear me?
President
Hi,
Denise.
Denise. Good afternoon.
Hi, good to see everybody.
Yes, Denise. Good evening.
Good evening. Looking forward to seeing everybody in December.
Yes. Good evening.
Oh, December you have an election.
Yes, this year we will have elections.
We vote for Denise.
No, I'm not running this time.
Not running, yeah.
Cannot.
Sorry to interrupt. So I think Ms. Tan from VT Healthcare will start the Zoom ready.
Yes.
So I think we can proceed at 5.
Yeah.
Okay.
Correct.
Oke, Bapak Ibu, sebentar lagi akan mulai. Saya menerima pesan attendance form error. Padahal di attendance form sudah ada 35 yang mengisi attendance form. Jadi itu tidak error. Bapak Ibu silakan di restart dulu perangkat.
Hi everyone from Asia and
langsung
all
ke Singapura.
over the world. This is CPD ASIA, online continuing professional development platform for Asian radiologic technology societies. And hosting the 20th CPD ASIA is the Singapore Society of Radiographers, SSR. And I am Peachy Luna, your program host. We are again grateful to our sponsor, VP Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search PARI and VART channels so you can join us live and or watch a replay using these YouTube channels. So this CPD Asia is highly supported and graced by member societies, presidents, the officers and representatives. Allow me to recognize all of them. Let us greet and welcome President of Macau Radiological Technologists
Hello, I am
Association.
Fernando. Good evening.
Hi, Sir President Fernando Koch.
Hi, hello, I am Fernando. Good evening.
We have also President of Vietnam Association of Radiological Technologists, VART President Thai Van Loc.
Good evening, everybody. Good evening.
For President of Perhimpunan Radiographer Indonesia, Indonesian Society of Radiographers, Dr. Gek Sugianto. We have President of Hong Kong Radiographers Association, HKRA, President Choon Dun Nelson.
Hello, everyone. Good evening.
We also have President Chun Yuan Tu of the Taiwan Association of Medical Radiation Technologists, TAMRT.
Hello, everyone. Good evening.
We also have President Sophie Lee of the Association of Cambodian Radiological Technologists.
Good evening, all President.
We have President of Philippine Association of Radiology Technologists, President Rolando Banares. And for Myanmar Society of Medical Radiation Technologists, we have Vin Yin Tan. So also joining us, the CPD Asia, are our two new presidents. We have Salva Kumar and the President Suresh Malayat Sekjen and CEO, and Tumi Bergkanch of the Mongolian Society of Radiological Technologists. So thank you very much, dear presidents and officers. Later, they will be joining us again during the Q&A session as our panelists. Also joining us are invited panelists from other countries. We have Madam Chan Lai Kwan of Malaysia.
Hello, everybody. Good evening.
We also have Sir Philip Cheung and Sir Jerry Lay of Macau. We have Sir Philip Cheung of Hong Kong. So before we start the program, may I humbly request all our presidents and officers, also with our speakers, to please open our cameras for a short photo session. All right, smile everybody. Cheese, 1, 2, 3. So thank you. And to formally start the program, let us all welcome the President of Singapore Society of Radiographers, SSR, President Denise Chu, for her opening speech and a welcome message.
Thank you very much, Peachy Luna. Good evening to all of you, my friends from the region, and a very warm welcome to the 20th session of the Asia Continuing Professional Development Program. I'm Denise, the President of the Singapore Society of Radiographers, and we're delighted to host you all this evening. So as World Radiography Day is drawing near, I hope everybody is getting ready to celebrate this wonderful occasion. Every year on the 8th of November, we commemorate the founding of X-ray and our profession, radiography. So if you have not seen it yet, please go to the ISRT Facebook page and download the poster for this year. Our theme is Radiographers at the Forefront of Patient Safety. So do take lots of lovely pictures with this poster, right, in your support for this theme for Radiography Day, right, and share it with us, so because we'd love to see how your country is celebrating World Radiography Day this year. As for our session this evening, I'm delighted to welcome two wonderful speakers. We have Tan Chun An and also Luqman Al-Hakim. So I will leave my esteemed colleague, Ang Sri Kai, who is a senior radiographer from NUH, and also the academic chairperson of the SSR, to introduce them formally. I hope you find this session very enriching and very exciting, okay, to learn about the new events that are going on in Singapore and how we have changed our practice with the incorporation of technology. So without further ado, I would like to bring Xu Kai to start the session officially by introducing our speakers. Thank you, everybody.
Thank you, Ms. Denise Choon, for the welcoming speech, and Ms. PG Luna for the opening of the 20th Asia CPD. My name is Xu Kai, and today we have an interesting lineup of 2 talks that centers around imaging processes within the emergency department. Within the emergency department, our first speaker for today is actually Mr. Luqman. He is a radiographer with 3 years of experience in Sengkang General Hospital, Singapore. Within their emergency department, triage nurses can order X-rays for patients based on their presented conditions, but it can also lead to patient safety concerns and issues when the orders are inaccurate. Let us hear from him how his team turned this around by using an educational tool to improve the accuracy of nurse-initiated X-ray orders. Mr. Luqman, please.
Hello everyone, my name is Luqman, and today I'm going to share with you our project, which is improving the accuracy of nurse-initiated X-ray orders in the emergency department. So just a brief background about myself. I graduated from SIT in 2019, and I'm currently the General Radiography Section Lead in Sengkang General Hospital, covering general radiography operations such as the emergency department, inpatient and outpatient services, as well as operating theatre. So nurse-initiated X-ray orders, or NIXO for short, is our initiative. There's a background of this project. In Sengkang Hospital, the ED triage nurses are privileged to order X-ray for patients prior to consultation with the doctors based on the initial presented complaints. This workflow was implemented to improve the efficiency of patient management in ED. The problem is that our radiographers find that there was an inaccuracy in X-ray requests ordered by the triage nurses in ED. So we have encountered several orders that were deemed inappropriate or inaccurate. Inappropriate or inaccurate X-ray orders are defined as X-ray orders that are ordered for incorrect region, incorrect site, or inaccurate clinical history. Such orders have led to several near-miss cases that could compromise patient safety and potential medical legal issues. It also subjects patients to unnecessary radiation. These are some examples of inappropriate or inaccurate X-ray orders that we have encountered by nurses. The first example is a thumb X-ray that was ordered for an indication of a left toe pain. Second example, a finger X-ray was ordered for a thumb injury. The third example was a wrist X-ray that was ordered for the wrong side. The last example is a wrist X-ray that was ordered for a complaint of arm pain, which was a vague description of a clinical diagnosis. So these are our proposed solution and aim. We have created an educational tool to aid in improving the accuracy of X-ray orders by the ED triage nurses. Firstly, we will conduct refresher lectures for existing triage trained nurses. We will do a revision of the X-ray order module for future triage courses. And we will also monitor the nurses' X-ray orders. We aim to improve the accuracy of X-ray ordering through proper education for the nurses. We have also submitted this project as a QI project in Sengkang Hospital. So more on the refresher lectures. So we did a series of refresher lectures for X-ray ordering that were conducted for existing triage trained nurses. There were close to 100% attendance and CPD points were awarded to the nurses. So these are the contents that we went through in the lecture. Firstly, the introduction of radiographic anatomical regions, an X-ray ordering guide on what X-ray to order for different clinical indications, and the implications of inadequate or inaccurate X-ray requests. We did a short quiz to test the understanding at the end of the presentation. A post-lecture feedback was also conducted, and 99% of nurses that attended found this initiative to be helpful in their clinical work. So for the revision of the X-ray ordering module for future TRIH courses, the content will be revised to align with NIXO education content, and the lessons will now be conducted by our own radiographers instead of the nurses previously. This is to ensure good understanding of X-ray ordering and the importance of it. We also go through the implications of wrong X-ray orders, and we will monitor the freshly trained TRIH nurses of the X-ray request for the first 3 months after they completed the course. For the monitoring of nurses' X-ray orders, the nurse in charge and our team of radiographers will monitor the X-ray orders that are ordered by nurses. Radiographers will flag out inappropriate or inaccurate orders, and we will review them every 6 months to identify potential problem areas so that we can address problem areas promptly. For example, to identify if it's a training problem or a personnel problem. We will review if refresher lectures are needed in the future. This is the timeline for our project. So we started the project in January last year, where we identified the problem and we collected data for our project from January to June. This was before we had the refresher lectures. So we had the refresher lectures in July 2021. And after the refresher lectures are conducted, we collected post-implementation data. So in February last year, we did our first revised TRIH course. And recently in October, we did our second revised TRIH course. There will be one more TRIH course this year, which is at the end of the year. So that's the plan for this year. So these are the content that we have in our package. Here's an example. So we describe the difference between a hand, finger, and a thumb X-ray. So we highlighted the difference between the X-ray so that the nurses are able to understand which X-ray orders to order for which indication. The same thing for ankle, foot, and toes X-ray, as well as cochlear X-ray. Another example of our content is to show them the routine projections of our X-rays and also explain to them which indication are appropriate for which X-ray orders. This is for tibia fibula. Let's move on to the data collection section. So initial data collection was carried out by our radiographers, flagging out inappropriate and inaccurate X-ray orders by nurses in ED. And with the help of the ED nurses, we obtained data of all X-ray orders by nurses in ED. And we cross-checked our obtained data with the nurses' data. And we calculated the percentage of the inappropriate and inaccurate X-ray orders against the total X-ray orders by nurses. So we collected the data 6 months prior to the first refresher lecture, which was highlighted in the timeline I shared earlier, as well as 6 months after. So this was what we analyzed from the data. So before the refresher lectures, there were 7.8% of inappropriate or inaccurate X-ray requests by the nurses. This data is for after the refresher lectures. We saw a quite significant drop to 3.9% in the end of inappropriate and inaccurate requests. So from this data, we can tell that the project has been pretty much successful. So we want to go ahead and go further in the project. So I'll share with you the current progress as of October 2022. So we have conducted 2 sessions of the triage courses, and we'll have 1 more session at the end of the year. We'll still continue with more triage courses in the following year. And for the data, initial data shows a steady improvement in the X-ray orders by the triage nurses. And we will do a full data analysis after the triage course that will be conducted at the end of the year. I'm going to share with you the limitations and challenges that we encountered for our project. The first one is manual data collection. So it was tedious to collect data because we had to manually flag out the X-ray orders and correlate them with all the X-ray orders that nurses have ordered. And we had to separate the X-ray orders between nurses and doctors. Also, there was a limited list of X-rays and projections that the nurses are allowed to order. For example, they are only allowed to order extremities, chest, KUB, and lumbar spine. And some of the projections that they can order are not aligned to our radiology protocols. So for this, we need to have further discussions together with the emergency department and clinical governments to address this situation. So here are our future plans and development. We will do a more in-depth data analysis with more data that we have collected and to identify the potential problem areas. And we will also review the need for yearly refresher lectures for the nurses. We are also open to sharing the curriculum to other institutions that have nurses ordering X-rays in ED as well. And we would like to explore possible extension of the curriculum to doctors to improve X-ray ordering accuracy. For this, we have already implemented for the ED junior doctors. We have conducted 2 sessions for their orientation program. So in conclusion, based on our initial data analysis, it suggests that NIXO has helped reduce the number of inappropriate and inaccurate orders made by the ED triage nurses. This interprofessional education initiative has provided ED triage nurses with the knowledge required to order X-ray competently whilst ensuring patient safety and providing quality care. The workflow in ED has also improved as time is not wasted by going back and forth with nurses to reorder an X-ray. These are my team of radiographers as well as nurses in the ED. And I'd like to give special thanks to those who have given their support to our team in this project. That's all for my presentation. Thank you and goodbye.
Thank you, Mr. Luqman, for bringing us through the interesting interprofessional learning at your emergency department. Next, we have Mr. Choon, senior radiographer with more than 10 years of experience, and he is currently the emergency department and CT in charge at the National University Hospital, Singapore. His talk is titled Optimizing Radiology Workflows in an Emergency Department, a single center experience from National University Hospital of Singapore. Let us hear from him how or what are the new implementations such as the next generation of electronic medical records and quality improvement projects amidst the challenging COVID-19 climate. Mr. Tan, please.
Hi everyone, good evening. I'm Choon from National University Hospital of Singapore. I'm honored to receive the invitation from SSR to share with you our experience in acquiring guidelines for radiology-related workflow in our emergency departments. These are the contents that we're going to go through today, including challenges that we are facing recent years, specifically on the outbreaks of COVID-19 and onboarding of next generation's electronic medical records, or in short, NGMR, that are introduced in our institutions. We're also going to share on some project frameworks or approach that we utilize in the process to acquire some of our workflows in the department, this including QIP, Equip, and some innovations project, which I will share more of the details in coming slides. Lastly, what is NGMR, how we incorporated our workflows into the systems, and benefits that NGMR brought to us pertaining to radiology workflows in emergency department. So this will be a bit of intro on our floor plan. Our emergency department do cover both children and adult cases. There are 2 X-ray rooms, 1 CT scan room, and 5 other portable DR that currently supporting the operations of emergency departments. Patients are categorized from priority 1, 2 to 3. P1 is of patients that require intensive care, P2 are mostly trolley patients, and P3 is of walk-in patients. We also have 3 isolation facilities in ED, which make up of fever facility that usually take up of P3 patients, Annex, which is an extension to attend to P2 patients, and ISO, which is P1 patients. Sorry that I'm not able to squeeze in the entire floor plan into a single slide. As you can see, some of the locations are actually quite scattered in emergency department. An increase of portable cases certainly bring us some challenges, especially in upkeeping of procedure turnaround time without compromising patient safety. Thus, it is extremely important for us to plan our workflow carefully. The first project frameworks that I'm going to present is Quality Improvement Project, or in short, we call it as QIP. In a QIP, we always start our project with a definition of problem, followed by a goal setting, a problem analysis pertaining to the issues that we are facing currently, and followed by intervention plans, and lastly, to measure the results that we achieve. An example here is our QIP to increase the proportion of posterior anterior chest radiograph in the emergency department. To clarify, this QIP was completed in year 2018, which before COVID. We have achieved the result that we doubled the proportions of PA erect chest X-ray from around 10% to 20% in year 2018. This was followed by a series of implementations, including acquired a safe protocols to perform PA erect chest X-ray for trolley and wheelchair patients. We also cleared our infection disease department to allow us to transfer isolation patients from ISO facilities to the X-ray room. But we face a huge challenge on the workflow when COVID-19 struck us, where the transferring of isolation patients to X-ray room is no longer allowed. As chest X-ray is the first line imaging for suspected or confirmed COVID-19 patients, it is critical to produce a good diagnostic image by performing the chest X-ray in PA erect positions. And we managed to overcome this by modifying our positioning technique and coming up with an innovations product that able to facilitate in PA erect chest X-ray in portable setting. I'll share more in a later slide where we're going to talk about our innovation product. As mentioned, portable workload has increased in close to threefold in our institution since COVID outbreak. We do face some patient safety issues initially. Due to lack of communications, no clear visibility on patient's X-ray status, and also multiple requests raised for same patients, there were a few near misses and incidents that happened where a couple of patients were almost or exposed twice for chest X-ray under a single request. With a series of interventions, including safety hurdles, provide risk pack stations at various portable locations, revisions of registrations and history taking process, and also by putting up visual aids to indicate patient's X-ray status, we actually managed to achieve 0 near misses and incidents, and we were able to sustain the result to date. We also incorporate the workflow when our institution first introduced with NGMR, and we do appreciate the benefits that brought by the new medical systems. Let me share more of the details in a later slide when we're going to talk more about NGMR. Next is another QIP known as PASS project to us that we carry out to tackle the increase of risk packs error in radiology procedure under emergency department. This was due to rapid changes of workflow and fast-paced environment in emergency department. The projects aim to reduce error in terms of patient ID, accession number, site, and site for EMD X-ray. As we all know, RIS-PACS is a medical imaging technology that allows storage and convenient access to image. Example of errors includes wrong marker, wrong annotations, and wrong patient's folder. There were high average number of errors in emergency department X-ray, approximately 11.12 errors per month. This potentially led to delay or wrong treatment to the patients. We actually came up with a very simple move by setting up timeout stations on each patient stop. As you can see, it is actually close to a no-brainer move. It doesn't require much effort. But surprisingly, by emphasizing on the importance of patients and procedure check, we actually reduced close to 86% of errors as compared to the peak, and the result is very sustainable. The PASS stations have since become an important part of our emergency department X-ray workflows. Next, to share on our EQUIP framework, a project framework that looking into improving clinical practice. This EQUIP project was targeting to improve accuracy of preoperative templating of hip implant size for hip fractures patients. Our project to include hip marker on every pelvic X-ray has improved operative planning and reduced the number of X-ray required for our orthopedic patients. Again, the implementation is not difficult. It's just a matter on how we provide the necessary tools, how we educate our radiographers throughout the process, let them understand the rationale behind it, and go through the learning curve together. By sharing the above QIP and EQUIP project, I would like to make a short summary here that to obtain a guideline or setting up a workflow, it may not be too complicated in the first place. Focus on patient safety and benefits at all times. try not to add too much steps into it, and make sure our peers understand the rationale behind each implementations. These are the key principles that we holding on when we setting up a workflow. Moving forward, I would like to share with you two innovations project by the team. First, on Passcode, it's a posterior anterior chest X-ray box that we found useful in performing PA erect chest X-ray in portable setting. Second is a SIR helmet to reduce the chances of or reduce the risk of contaminations during CT, MR, and IR procedure, especially when performing procedures on COVID-19 patients. As chest X-ray is the first line imaging for suspected or confirmed COVID-19 patients, it is critical to produce a good diagnostic image by performing the chest X-ray in PA erect positions. Passcode was designed to hold a DR detector. It was lightweight and very durable. It's easy to carry with our portable machines. So when Passcode is not available, we actually modified the positioning technique by having the patients to hug the X-ray detector in a standing positions, X-ray beam to angle from a PA positions. This allows us to achieve a relatively better image quality compared to AP erect chest X-ray. We also designed a SIR helmet to be used, as I mentioned previously, for procedures such as MR, CT, and IR. Negative pressure within the helmet is generated by connecting a standard medical gas wall vacuum using extension tubing via a port in the barrier shield. This is a mini version of a negative pressure room to making sure that the air particle is not spread outside of the helmet. Next, we're going to talk about our portable workflow. EMD Annex is an extension to accommodate P2 or P3 patients with ARI symptoms. It consists of 18 patients cubicle and 1 X-ray cubicles. The X-ray cubicles is actually lead line, and the intention of having the X-ray cubicle is actually to make sure that all the X-ray procedure will be carried out in the X-ray cubicle in considerations of radiation safety. But we found out that during the first week of operations, the total portable X-ray procedure time was high. This was due to limitations of manpower and restricted space to transfer patients to X-ray cubicle. As much as we want to cut short the procedure time, radiation safety towards patients and staff in that particular area remained as a concern. We then decided to carry out a radiation dose simulation within the area. The beam was fully intercepted by a 14.5 cm phantom used to simulate an adult patient. Scatter measurements were taken at 3 areas of concerns, as we can see in the diagram here. Will be from point A, point B, and point C. Results shown that chest X-ray exposure has scattered radiations below the regulatory limit of 10 millisievert, and it is safe to perform chest X-ray in patient's room without lead line. Radiation scatters, and we found that radiation scatter survey could be a feasible approach while setting up a portable service, should it be in emergency department or ward settings. By revision of the workflow, we actually managed to reduce downtime when performing portable cases. The downtime that being mentioned here are referring to the six components that shown in the slide. By eliminating the step to transfer patients, we actually reduce transferring time for sure. And nursing manpower can now be focused on attendance to patients rather than wasted on the transferring or motion of patients. We achieve an estimated of 40% in procedure time, as in reductions in procedure time. By doing so, to be more precise, we save about 7 minutes per procedure. So, anyone ever heard about time is brain, or or penumbra is brain? So these are the two quotes that are often used by our neurostroke doctor to emphasize on how important is the effect of time in acute stroke cases. It is extremely crucial to deliver treatment to this group of patients in a timely manner to reverse the brain stroke. Having said so, it becomes our responsibilities to provide relevant imaging as soon as we receive the patients. By targeting to reduce downtime, we have revised our hastened workflow in year 2020. The main changes including to receive patients straight from ambulance into CT room, history taking and patients assessment to be carried out in the scan room as well. These have reduced transferring time and patients' movement. And scan can be performed faster compared to our old workflow, where triaging of patients and patient assessment need to be carried out in P1 observation area. Then they will transfer the patient to scan room after the assessment being carried out. So again, a short summary for the previous few slides. From our experience, when setting up a workflow, try to be creative, I would say. And we find that a more efficient or safer approach may not require extra steps, but in fact, by eliminating some unnecessary one, we're going to achieve a better outcome. So lastly, we are going into the last part of this presentation. It is regarding our next generation electronic medical record, or in short, known as NGEMR. This is the system that moving us towards a one patient, one record at the national level. It replaced our previous systems such as CPSS, which is a patient medical records. Aurora, it was our ordering systems. EMAR, which is our medications and administrations records, and also our operating theater scheduling systems. These are some of the changes that we experienced with the rollout of NGEMR. We actually eliminated the usage of hard copy request form for our priority 2 and priority 3 patients. And I would like to bring your attention to this ED trackboard in NGEMR, which is more ED related. All the relevant informations are available in one glance. From the ED trackboard, we'll be able to locate the patient easily. We'll be able to look at patient history or indications. We can even look at the UPT result or status in the trackboard itself. And just by hover all over to the red order, we'll be able to see what procedures that actually requested for the patient. And yes, all these are just within a single interface, which make it more convenient for our X-ray or CT scan procedures. And by clicking on the patient's role, we'll be able to pull up the request form easily as well. This provides us a strong fundamental to roll out the paperless workflow where all the informations are easily accessible in one interface. Lastly, just sharing from our experience, NGEMR actually brought us several benefits. Those that I would like to highlight here include how the platform actually reduced downtime for our portable workflow. With the information provided in ED trackboard There's no need for phone call activations, just like our old workflow. Radiographers able to keep track on the X-ray requests easily and attend to the patients. It also enables us to reduce the usage of physical request form or any sort of physical forms needed for the medications records as well. With all the patient's information easily accessible in a single platform, it actually improves our patient safety. For instance, if there is duplicated order requested for the same patients, we'll be able to pick up easily in the system, and this will prevent some serious reportable event from happening. Lastly, it's also save our time where there's no need to toggle from one interface to the other, just to looking for patient's history. Radiographers also able to take initiative to so-called pull the patients from respective area for X-ray procedure, where this wasn't able to achieve previously because there's no trackboard that's showing patient locations. So having sharing all the good things about NGMR, it actually wasn't easy for us at first. But in my point of view, we actually tanked through the learning curve and eventually appreciate the system more as of now. So my friend once told me about his feeling towards NGMR. I quote here. NGMR is just like the other half. You might find he or she annoying at first, but when you get to know them better, you'll be able to see more good than bad in them. With this, I'm going to end my presentation. Thank you everyone for your time and have a great weekend ahead. Thank you.
Thanks, Choon for the wonderful sharing of various key implementations to improve the ED processes. We will now move on to the Q&A segment. So participants, you may key in your questions in the Q&A chat box, and then we will visit them later after the panel. May I also now call upon the speakers and panelists to participate in this Q&A segment. Is there any questions from the panelists that we would like to ask our two speakers?
I have a question.
Yes, President Lok.
That's okay. Oh, you have to present to let very well interest. In my country, I don't know. We not yet have an NGEMR. I'm not have experience. You have an NGMR very well already interested. We will learn from you. I don't know how in Hong Kong you have NGMR like in Singapore. You can share experience or Macau. You can have and you share for everybody. Thank you so much. Congratulations to the topic today. Very well. Thank you so much.
Any presidents or representatives from other countries would like to share any related experiences with the electronic medical records, if any? I think Choon actually mentioned all the good things about NGMR, but of course it's not as colorful as it seems. Maybe I'll just start the ball rolling and ask one question to Choon. So was the learning curve steep for radiographers to get used to the interface? Because I see like there's a lot of things, a lot of icons and tabs. And so what are some of the initiatives that you guys or the team help radiographers overcome the anxiety with this new system?
So as I mentioned earlier, it's like getting to know your new partner. It definitely difficult at first, because imagine we already familiar with some of our current system for such a long period. Some of it maybe over like 10 years, 20 or 15 years. So those systems like our CPSS, EMAR, OODS, then a sudden big switch into Epic, for sure we feel lost at first. So from my point of view, training will be the key component. to make sure the smooth transitions from the current system into Epic. And just to share on our experience, our training actually started few months, or as we roll out by phases. It was started few months before the rollout of NGMR. It started only with 2 credential trainer, or we call it CT, followed by a pool of key user, then lastly to all of our radiographers. So during the initial stage of NGMR, we also make sure that there's actually peer support, especially from our key users on the ground that are able to facilitate in the workflow. I guess, yeah, these are the 2 key items that is some of the anxiety from the ground.
Yes, I do agree that you know, because something that's new to us, we definitely need a lot of training practice, and I guess peer support is one of the very important elements as well, so that we help each other in times of need. Thanks for the answer, Chunan. So we actually do get another question from the attendees, one of which is also related to this NGMR, so probably we'll go for that first. So one of these attendee asked, since there's no hard copy, how radiologists would get to know about the multiple parts of the X-rays?
Okay, so apparently, right, the Epic system is actually linked to our risk pack system as well. So from the risk pack system, we actually able to see each of the procedure that requested, and actually the result, as in the history, where we link up to the risk pack system as well. So to answer your question, it's actually by picking up the request from our risk pack system, and the sync of result will come after the reporting.
So from what I understand, essentially this NGMR is not is like a separate interface from risk packs, right, Chunan?
Yep, that's right.
Okay, so in this case, is there any like concerns or challenges, especially when these 2 softwares, where the radiographer has to toggle between these 2 softwares?
Toggling of the software, I actually doesn't see that as an issue, because it's all about like getting familiar with the system itself and the navigations, how to locate the informations that required for each system is actually not too complicated from my point of view.
Right. Okay, thank you. Would any panelists like to ask any other questions for Chunan or Luqman?
Yeah, Shukai, if I may.
Yes, please.
Yeah, so first I'd like to congratulate our 2 speakers and NUH for sharing very good innovative action plans and projects and programs. I'm interested first in NIXO. Our speaker is the lead RT. Can you share to us, as the lead for that NIXO project, the reception of the nurses, because we know that it's a different department. And can you share to us how receptive the nurses, the lead nurses and the staff to this project? Can you share to us what did you do as you introduced this to the nurse department? And then second, to our last speaker about QIP, the presented interventions and action plans. Can you share also how a particular program under QIP can be initiated? Because I think you are continuously coming up with programs for quality improvement in your hospital. Can you share to us the process? Like, is it a policy? Is it a part of the department's policy to always have programs under QIP? How do you proceed with presentation of a program? Do you have to discuss first to seek an approval before you try to conduct and do this in your department? Thank you.
Hi, Luqman. I think your mic is muted.
Can you hear me now?
Yes.
Okay. Yeah. So when we introduced our project NIXO, to the ED nurses. So the nurse in charge was actually quite encouraged by the idea, and they were very supportive of the idea, and they wanted to work with us. They saw the value in it, and then they were happy to work together with us, and their support was really very good. They helped us a lot in terms of the content curation and as well as the data collection. Yeah, so and about the nurses that attended the courses, they were also very happy to let us, like give them lectures and educate them better. And I think it's a good collaboration between two different departments. And yeah, it's very rare to see radiology departments collaborating with other departments. Usually it's within the radiology department itself. So yeah, I think this project really forged a better relationship between the nurses as well as the radiographers. Yeah.
Thanks, Luqman, for the answers. Actually, as an extension, there's also one participant from Indonesia who actually asked question relating to this NIXO project. So the question is, because this is focused on the ED nurses, his question is, was it tested on polyclinics and other areas of the healthcare system?
So for our project, because I'm from General Hospital, Sengkang General Hospital, so the project is just contained within our emergency department. So we didn't really have any chance or opportunity to test it outside of our hospital. So, but maybe in the future, who knows, there might be opportunities to expand this project further, and maybe those from other organizations, other hospitals or polyclinics who are interested to, to use our curriculum or our program and implement in their own hospitals or clinics. They can feel free to, contact me, or yeah, we can work something out. Yeah.
Yeah, and I also feel that a lot of these nurse initiated X-ray orders is more applicable in the critical care or the emergency department, because that's where speed is essential.
Yes.
Yeah, because I guess a lot of other X-ray orders may be a bit complicated, and it may be very specific to certain regions, which require more experience and more judgment in passing some of those orders, as well as it does involve some kind of medical legal issues as well.
Yeah. So that's why for our hospital, the nurses are only allowed to order certain X-ray orders. So we are just limited to that. Then the other orders, all those complex orders, probably the doctors will be the one ordering instead of the nurses. Yeah.
So in this case, there is actually another question that I thought would be good to have you enlighten us as well. So on this NIXO, on this nurse-initiated X-ray orders, what would be the first thing that a radiographer would do in emergency or stat cases if the nurses gave a wrong X-ray request?
Okay, so in cases where the X-ray is urgently needed, and let's say the X-ray is ordered wrongly by the nurse, for radiographers, what we tell our radiographers is that we'll just go straight to the doctor in charge of the patient, and then just confirm with the doctor what is the correct X-ray that he wants. Then we just get the doctor to order, and we do the X-ray after that. Yeah, so we don't waste time we just don't waste time going to the nurses and asking to change. We just go straight to the doctor since it's stat. Yeah, so it saves time and give our patients better treatment as fast as we can. Yep.
Seems like this nurse-initiated X-ray orders does gain quite a bit of attention here. And there is another question that's also related to this topic of interest. What are the actual causes of the errors? Is it because from the tenured triage nurses or the newer ones, or is it because that they do not know, or have they forgotten?
I think when we started the project, we reviewed what could be the cause of it is probably because before our project, when they had their triage course, they had a section where they were taught how to order, but it's more of the technical part, like just how to order, but not more of what X-ray to order for what kind of diagnosis or condition. Yeah, so when we came in and we started this, our content mostly revolves around that, like the understanding of what kind of X-ray, what type of X-ray to order for what kind of indication. So and I if I may add on, like what we found that was a common mistakes usually is like those finger X-ray versus thumb X-ray, hand versus wrist. You know, like they just see the hand is swelling or the wrist is swelling, and they just order a hand instead of a wrist. Yeah, so these are the things that they don't really have knowledge on, or like the proper radiological or radiographical knowledge. So that's where we stepped in and we curate our content around that, so that they have a better understanding and they can order the X-rays correctly. And also after we started this, we also realized that when the nurses have any like they don't know what to order, they will actually come and ask the radiographers and ask for their advice, like what should I order for this, and etc. Yeah, so I think that's quite good, because at least they have the they can ask us whenever they have any qualms or any questions. Yeah, so yeah, it's a teamwork, like just between the nurses and the radiographers, so that basically working towards the same goal, which is giving patients the best care. Yep.
Thanks, Luqman, for the answer. I guess education really forms the fundamental basis of everything, and also teamwork that plays an important role in ensuring, everyone move together and progress. And that's what we are actually advocating on this CPD Asia as well, where there's interprofessional learning taking place. And just one last question, maybe to Choon. I think we have one from another attendee, is that for NGM, just like any medical record system, are there still instances when the system may be down due to software and hardware issues, or is bugging on a single patient? And what is the plan when the system is down to ensure that patient care is still maintained? I think Choon would have the most experience in this and probably can shed some light on in this aspect.
Okay. I mean these are very valid questions. In fact, we just encountered a couple of issues previously over a span of 1 or 2 months. So when we first roll out the new system, right, we actually pre-plan our downtime workflow as well. So I think this take a so-called major role in handling such instances where there are unforeseen system downtime. So we actually mapping out the so-called downtime workflow and get it vetted by all the stakeholders, and make sure that there are common understanding between various stakeholders. Should it be clinicians, should it be radiographers or nurses, to work on the downtime when it happened.
Right. Thank you for the answer. Right. Okay. If there are no more questions, I'll hand the time over back to Peachy.
Yes. Thank you to our session moderator, Mr. Chairperson Shu Kai. And thank you very much to all our presidents and all our panelists. So the Singapore Society of Radiographers, SSR, has just provided us with 2 great speakers who have just shared to us very interesting discussions. And in the interest of time, we have to cut from here to give way for the closing session. So again, thank you so much to our distinguished speakers. We really have learned so much from your interesting and important discussions. So Shukai, this year ends with most exciting and most anticipated events. Next month, we will be celebrating the World Radiography Day. Let us all join the activities as we celebrate the great works of all the RTs and radiographers at the forefront of patient safety. Also, we are all excited for the upcoming ISRRT World Congress 2022 in Bangkok, Thailand, to be hosted by the Thai Society of Radiological Technologists, TSRT, happening on December 15 to 17, 2022. We are all excited to meet and learn from great speakers live in person. So in closing, congratulations to Singapore Society of Radiographers SSR President Denise Choon, all the officers and the organizing committees of the 20th CPD Asia. And again, we always thank the support of our sponsor, VT Healthcare Vietnam. We are also grateful to our great speakers, Sir Luqman Al-Hakim and Tan Choon An. Most of all, we are sincerely grateful to all the member societies presidents, to our very hardworking CPD Asia IT team, and to all our registered participants who have made this online CPD Asia program a success. We'd like to see you again in the next Asia CPD. Again, I'm Peachy Luna, and I say thank you, everyone. Have a great day.
Thank you, Peachy.
Thank you.
Thank you, Denise.
See you all in December. Bangkok.
Thank you, everybody.
Long time no
Denise,
see.
thank you.
Good to see you in Bangkok. December.
See you December in Bangkok.
Yes, see you. Goodbye.
Yeah.
Bye.
Bye.
Bye. See you all in December. Bye bye.
Yeah.
Congratulations,
Yeah.
SSR.
Miss Chan.
Thank you for the support,
Shukai,
everyone.
President
Thank
and Chung
you.
Joystan.
Yeah. Thank you. Thank you.
Thank you.
See you all
Lok,
soon.
hello, Lok.
Yes.
Yeah.
Thank you.
Thank you, everybody.
Thank
Thank
you,
you, everybody.
Sir Sabanti.
Yeah, bye-bye. See you.
Bye-bye. See you.
Bye-bye, everyone. Thank you, Shukai, President Chung.
Thanks, PG. Bye-bye.
Ya, demikianlah Bapak Ibu sekalian, rekan-rekan sejawat yang ada kesempatan hari ini.
Baik Bapak Ibu, demikian tadi CPD Asia ke-20 atau 20th CPD Asia was done by Singaporean Society of Radiographers. Kemudian Bapak Ibu, dalam kolom chat Zoom sudah diberikan link untuk post-test, dan sebagai penutup kami mohon kesediaan Bapak Sekum PP Pari kita, Bapak Hidayat Agus Sabarudin, untuk menyampaikan salam atau pesan penutup kepada kita semua. Kepada Bapak Sekum, waktu dan tempat dipersilakan, Pak.
Ya, terima kasih, Ibu Tuh. Ya, mohon maaf barangkali kalau suaranya agak berisik ya didengar karena saya sedang berada di luar. Ya, terima kasih teman-teman semuanya. Bahwasanya kegiatan yang kita laksanakan sore ini CPD Asia yang ke-20 yang diselenggarakan oleh Radiographer Society of Singapore, yang mana mudah-mudahan bisa memberikan manfaat bagi kita semua. Dan tentunya sekali lagi inilah perkembangan teknologi. Tadi disampaikan materi yang sederhana, tapi disampaikan gitu ya. Hanya materi-materi yang simple tadi. Mungkin ide kita tentunya ini bisa memberikan satu, katakanlah mungkin ide bagi kita, hal yang sederhana, tetapi jika ditampilkan dengan keupdatean ternyata memberikan satu manfaat. Jadi janganlah berpikir kita hanya yang sulit-sulit, yang advance saja materi-materi yang disampaikan, tetapi ternyata materi yang kalau kita simak tadi adalah materi yang cukup sederhana tetapi update ya. Terima kasih teman-teman semuanya. Mudah-mudahan ini bisa memberikan manfaat bagi kita semua. Mudah-mudahan juga kita bisa ketemu lagi di CPD Asia yang ke-21 yang akan datang. Dan terus semangat, tetap jaga kesehatan. Mudah-mudahan kita semua senantiasa diberikan keselamatan oleh Tuhan Allah Subhanahu wa Ta'ala. Amin. Terima kasih pada Beli Putu.
yang sudah senantiasa selalu menyiapkan dan memfasilitasi kegiatan CPD Asia ini. Terima kasih Bli, mudah-mudahan membawa berkah bagi kita semua ya Bli ya. Terima kasih.
Ya, terima
akhir
kasih.
kata mari bersama-sama mengucapkan terima kasih dan alhamdulillahirrahmanirrahim. Mudah-mudahan kita dapat bertemu dan bertemu kembali di lain waktu. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Pak Sekum. Dan sebagai penutup juga laporan Pak Sekum bahwa pendaftar kita pada CPD 20, CPD yang ke-20 ini adalah 239 pendaftar Pak Sekum. Kemudian yang mengisi tadi pretest ada 98 dan masih dibuka sampai saat ini. Kemudian yang absen akhir baru 25. Dan di kolom sertifikat, kita juga menyampaikan kolom sertifikat itu ada 31 yang mengisi. Jadi ada 4 form yang diperlukan untuk CPD Asia ke-20 ini, Pak Sekum. Demikian laporan kami. Ini 239 yang di Zoom 96 tadi. Demikian laporan penutup kami, Pak Sekum. Terima kasih, Pak.
Ya, terima kasih Bli. Mudah-mudahan ini senantiasa selalu memberi semangat ya buat teman-teman semuanya. Alhamdulillah ini 95 masih bertahan. Ini tentunya satu capaian atau satu bukti bahwasanya teman-teman kita Radiographer Indonesia ingin selalu mengupdate dan ingin maju ya. Terima kasih teman-teman semuanya. Ya, ini memang untuk Anda semua dan saya harap teman-teman bisa terus berpartisipasi dalam kegiatan CPD Asia ini. Yang mudah-mudahan inilah bukti bahwa Radiographer Indonesia mampu bersaing atau mampu membuktikan kompetensinya serta tentunya adalah identitas kita bahwa Radiographer Indonesia bersama dengan Radiographer di Asia kita saling bahu-membahu dan kita memiliki kontribusi. Ya Bli ya, terima kasih banyak Bli.
Terima kasih Pak Sekum. Baik, saya izin menyapa dulu teman-teman dan untuk post-testnya sudah ada. Silakan teman-teman itu di dalam Zoom sudah ada post-testnya. Dan ini ada direct message. Sungguh sulit kirain post-testnya soalnya sama kayak pretest hidup tidak semudah itu. Jadi post-testnya memang beda tergantung dari materi yang ada. Jadi materinya adalah tentang NIXO ya, tentang nurse order. Itu konsepnya bagus. Jadi perawat itu untuk ordering X-ray kadang mereka bingung dan ini pun terjadi pada kita. Kadang kalau ordernya genu gitu kadang kepencetnya elbow ya seperti itu misalnya. Dan di Singapura untuk menangani itu mereka sedang mencoba project NIXO ini. NIXO ini sebuah aplikasi yang berisi nama dan gambar dari objek anatomis. Jadi mereka nurse itu diajak untuk mempelajari objek anatomi X-ray. Yang ini namanya ini, gambarannya X-ray-nya begini. Ordernya nanti begini. Itu ceritanya tadi itu. Yang kedua saya tidak fokus ya. Saya tidak fokus karena saya ngambil soalnya itu dari yang pertama. Ketika pembicara yang pertama itu ngomong, jadi saya ketik langsung soalnya. Kalau agak sulit mohon maaf, itu semua materi dari pembicara yang pertama. Demikian. Kemudian sertifikat ini ber-SKP atau tidak, kalau sesuai dengan aturan yang ada di pari.or.id dan itu juga sudah disampaikan dalam post-test dan di kolom pendaftaran, bahwa secara langsung tidak ada SKP-nya. Syarat dari SKP satu SKP webinar adalah minimal 3 jam. Itu bisa dilihat di pari.or.id. Namun rekan-rekan silakan kalau mau untuk mengurus SKP-nya bisa bersurat seperti yang aturan yang diberikan dalam pendaftaran dan dalam post-test yang tadi pretest pun ada. Begitu teman-teman ya. Kemudian sudah ada CP-nya juga, CP lewat email. Kemudian di form di 20 ini, di form 20 ini juga kita menyediakan form untuk sertifikat. Sertifikat bukan dari kami tapi langsung dari Singapura. Ya. Kemudian persyaratan dari CPD Asia itu harus hadir minimal 75% kehadiran lewat Zoom. Kemudian ada pre dan postnya juga sama, lalu terdaftar. Jadi di form itu kita buat bahwa ada screenshot pendaftaran, kemudian ada screenshot pretest, dan disampaikan berapa nilai pretestnya. Kalau tidak ada nilainya, tulis saja strip, kemudian nilai post testnya berapa, lalu semua hasil itu kita akan post ke Singapura. Jadi Singapura yang akan memberikan daftar nama-nama yang berhak untuk mendapatkan sertifikat. Begitu ya. Jadi bukan dari saya. Banyak banget yang WA ke saya, banyak yang japri ke saya. Apakah ini bersertifikat? Mohon maaf, saya hanya menyiarkan. Tugas saya di IT, mohon maaf kalau mengecewakan jawabannya, tapi itu yang terjadi. Saya tidak ingin menyampaikan informasi yang tidak lengkap ya, atau tidak penuh begitu, setengah-setengah tidak. Jadi seluruh sertifikat nanti dari penyelenggaranya dengan syarat masing-masing. Kalau teman-teman kemarin ada yang ikut CPD sebelumnya belum dapat sertifikat, mohon dicek dulu apakah sudah rekan-rekan sudah terdaftar, apakah sudah ikut minimal 75% seperti yang disyaratkan, apakah mengisi pretest, apakah post-testnya sudah minimal 70% nilainya, dan seterusnya. Ya. Ya, silakan. Gusti Nirwana tidak ada disebutkan seperti upload. Silakan dicek lagi formnya, ya. Dibaca baik-baik pelan-pelan. Jangan hanya sepintas lalu. Begitu. Upload registrasi dan lain-lain di formnya lihat, ya. Saya belum bisa isi sertifikatnya ya. Di situ ada mandatory, ada tanda berbintang. Kalau tanda berbintangnya tidak diisi ya tidak bisa lanjut, ya. Silakan pelan-pelan, ada waktu hingga tanggal berapa? Tanggal 29 hari ini hingga pukul 22 WIB. Silakan dipelajari kalau memang rekan-rekan ingin mendapatkan sertifikatnya. Kemudian kalau untuk mendapatkan ilmu saja, rekan-rekan bisa ikuti CPD ini secara gratis tadi. Kemudian juga live di YouTube PP Pari, silakan. Jadi ilmu untuk CPD ASIA itu gratis. Yang mungkin perlu usaha adalah sertifikat untuk memperolehnya. Dan kemudian kalau mau di SKP kan juga sudah ada caranya. Sudah disampaikan di situ juga. Semoga ini bisa menjawab seluruh pertanyaan rekan-rekan dan semoga tetap semangat mengikuti CPD ASIA, ambil ilmunya, ambil idenya dari luar negeri, idenya mungkin simpel, silakan diaplikasikan sebisa kita di Indonesia dan lain sebagainya. Teman-teman ya, demikian yang dapat saya sampaikan. Tadi terima kasih Pak Sekum sudah menutup acara. Kemudian Bapak Ketum juga kita lihat hadir di Singapura tadi, di CPD ASIA Singapura, di sela-sela kesibukan Bapak Ketum. Bapak Ketum juga sore ini tadi dikabari sedang memandu diskusi di Kementerian Kesehatan, dan beliau tadi menyempatkan diri hadir di situ, luar biasa Pak Sekum, terima kasih. Pak Ketum, Pak Sekum juga sepertinya tadi ada berkegiatan juga. Dan demikian tadi teman-teman CPD ASIA ke-20. Selamat berakhir pekan, selamat hari Sabtu. Selamat weekend, selamat liburan, semoga sehat selalu, dan sampai jumpa di CPD ASIA selanjutnya. Demikian ya. Lalu teman-teman nanti kalau ada pertanyaan silakan posting ke email yang disebutkan, atau teman-teman bisa mengisi di form itu ada is there anything you want to express? Nah, silakan diisi apapun yang menjadi pertanyaan teman-teman ya. Sekali lagi, ini sertifikat bukan dari Pari, bukan dari saya, tapi langsung dari penyelenggara, dari hostnya, Singapura, entah yang mana lagi. Dan ada ketentuan yang diberikan. Demikian teman-teman, saya izin end meeting for all. Terima kasih atas kebersamaan kita sore hari ini. Saya akan stop recording dahulu.